بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Today's lecture regarding the anterior segment OCT in daily practice and its clinical application. Before we have spoken regarding the basic principles and the physical principles behind the anterior segment OCT. Today we'll complete our journey in this regard and speak about its application in the clinical field and the quantitative analysis and the clinical decision making. I am Dr. Jamal Ben Nasser. I will take this step with you, and I hope that will be able to elaborate a lot of the clinical applications of the anterior segment in daily practice, to the extent that it became one of the gold standard for any eye healthcare system, so that we need to know everything from the physics and the principle up to the clinical applications and then the future prospects. So not as a doctors only, but as a postgraduate students, you need to know everything about this technology, because you are exposed to be asked by the examiners for any aspect of this technology. So I welcome you again, and I hope that you will enjoy in this journey, and I wish for you the best of luck. We will start with the learning objectives of this lecture, and we will provide detailed anatomy of the anterior segment and the cornea and the angle with some of the quantitative analysis and the biometric data. We will start speaking about some different diseases and its clinical application, and finally about the limitations and the future. So by the end of this lecture, you will be able to know all these informations. As far as the clinical applications, we will concentrate on application in glaucoma, as well as in the corneal diseases, ocular surface diseases, and in keratitis and refractive surgery, also in IOL implantations, and then we will speak about the future prospect and provide final summary. Now we will come to the detailed anatomy of the anterior segment, and this is very important in the understanding of the anterior segment OCT to identify the key structures in the anterior segment OCT map, so that we can identify any abnormality present. This is a view of the OCT map. When you see the OCT map, this is a two-dimensional construction of the anterior chamber and or the anterior segment. You can see the cornea and you see the anterior chamber as well as the iris, and you can see only the central part of the lens, because the remaining parts are hidden behind the iris, and as you know, the iris is lined by pigmented epithelium, so the rays cannot penetrate here. And this one of the mild drawback of the anterior segment OCT, that it cannot determine the details of the ciliary body as compared to the UBM. That's the ultrasound biomicroscopy, in which we can see the details of the ciliary body by UBM. So by just looking to this picture, you know that this is an OCT and not a UBM, because only the central part of the lens is visible. So this is hyperreflectivity from the lens in the central part only. So this is an OCT map. Another structure is important. We will you can see this is the junction between the corneoscleral junction, in which the cornea is inserted in the sclera, and accordingly will determine the scleral spur. This is high resolution image of the details of the cornea. The first layer is the hyperreflective layer of the tear film, and followed by hyporeflective layer of the corneal epithelium. Then the reflectivity will keep on increasing to the stroma, and then to the Descemet's membrane and endothelium. So the endothelium is hyperreflective layer, however the epithelium is hyporeflective layer. So this is some of the important markers of the corneal thickness in the center and the periphery, also the epithelium thickness in the center and the periphery. And this is detailed structure of the cornea as well. This is more detailed information about the structure of the angle, and this is one of the main advantages of the anterior segment OCT, is to study in details the angle structure. The most important structure is the scleral spur, which is the inward projection of the sclera, where the cornea, the junction between the cornea and the sclera. And this is the reference for any quantitative assessment or measurement of the angle. From the scleral spur, if we go 500 micrometers and then draw a perpendicular line, which is written shown here in red color, from the inner surface of the cornea to the iris, this is known as AOD, that is the angle opening depth or angle opening distance, which is normally between 500 to 800 micrometers. We can use the line from 500 microns from the scleral spur or 700 or 800 micron from the scleral spur. Now all this area, trapezoid area, is known as the TISA. Also, this is very important landmark, which stands for trabecular iris space area. Trabecular iris space area. This is the normal boundary. So we will study this in details later on, but keep it in your mind that determination of the scleral spur is very important so that we can study quantitatively the diameter and the detailed structures of the angle. Other important details that we should study in the anterior segment anatomy is the iris configuration, ranging from normal iris configuration in which it is parallel to the corneal surface, or very mild concavity based on the vault of the lens, or concave iris configuration, which is commonly seen in pigment dispersion syndrome, or convex iris configuration in people with glaucoma suspects, or the plateau iris configuration in which there is anterior insertion of the iris and the iris is pushed forward from the anterior ciliary process due to abnormality in the ciliary body. Also, the details of the lens position as far as the vault, the swelling, the depth, and the width of the anterior chamber, and every details about the lens. This is important in the etiopathogenesis of the phacoemorphic glaucoma. Another thing is the study of the details of the ciliary body. As you know, as I said before, that the anterior segment OCT will partially show the ciliary body because of the pigmentation on the posterior surface of the iris, unlike the ultrasound biomicroscopy, which can show the details of the ciliary body. And this is very important in the etiopathogenesis of the plateau iris syndrome. As I said, plateau iris syndrome due to abnormality in the ciliary body and forward projection of the ciliary process, and hence it push the iris forward, making the ciliary sulcus or the angle sulcus very narrow or sometimes closed. Another important things regarding the pupil size, determination of the pupil size, and this is perhaps one of the advantage of anterior segment OCT over gonioscopy, that in gonioscopy we cannot assess the angle in details because we are using the light will induce meiosis and will artificially opens the angle, so it will not provide you a real assessment of the angle. However, in the OCT we overcome this by examining the patient in dim illumination so that the pupil size will not affect the or the meiosis or dilatation will not affect the assessment of the angle width. So this is very important. It is demonstrated that for 1 millimeter change in the pupil size, the angle opening distance at 500 micrometer will be changed by 94 micrometer, and the TISA area, as explained earlier, will be changed. So the examination in relation to the pupil is very important. Now we will start our discussion on one of the main important clinical application of the anterior segment OCT is the study of glaucoma and the angle closure disease. Angle closure disease means that it is a spectrum from acute angle closure suspect to acute angle closure and then to acute angle closure glaucoma. Now, as you know, one of the applications of the anterior segment OCT is the biometric data and quantitative analysis of the angle of the anterior chamber. But before that, let me give you some limitations of the gonioscopy, which is available before the occurrence of the anterior segment OCT. That this gonioscopy is mainly dependent on the experience and the expertise of the examiner, and you need a long learning curve to be able to determine the different structures. Also, there is a huge inter-observer variability reaching between 50% to 80% between doctors. And apart from this, the discomfort exerted to the patients and the light that we apply, it will induce meiosis, and this meiosis will open the angle, so the assessment will not be very precise. This is one of the some of the limitations of the gonioscopy, and also the compression on the eye and the pain induced to the eye. That's why the shift toward a non-invasive way of very quantitative analysis of the angle is very useful in this regard. So there is a lot of quantitative angle assessment and angle parameters that we have to study them in details, especially what's known as the angle opening distance and the trabecular iris space area, TISA. Now, as I said before, that one of the important landmark to determine these two variables is the determination of the scleral spur. The scleral spur is here. We have to determine the scleral spur. Based on that, we can determine the angle opening distance and the trabecular iris space area. And there are certain normal range. For example, an angle opening distance between 500 to 800. Below, then this value indicate that it is occludable angle if it is less than 250. Also, the TISA area, which is normally between 0.15 to 0.35. If it is less than 0.1, it is an occludable angle. So we will study in details how to measure these variables. For example, you can see here that once we determine the scleral spur, we go tangential with the corneoscleral junction around 500 microns and determine this point. If we drop a perpendicular line to the anterior surface of the iris, this is known as the angle opening distance, which is 500. It is 500 micrometer from the scleral spur. Now this is very important variable because, as I said, if it is less than 250, this indicate an occludable angle. The more important than this figure is the TISA area. Area is not a fixed figure, but it is the area. This area bounded by the corneoscleral junction anteriorly and the anterior surface of the iris posteriorly, and from the scleral spur up to this perpendicular line from the posterior surface of the cornea to the iris. So all this area, normal range, as I said, between 0.15 to 0.3. If it is less than 0.1, it is occludable angle. So the TISA area is very important variable. We have to determine it in any case of angle closure glaucoma or glaucoma suspect or people with plateau iris and so on. As I said before, that the angle closure diseases spectrum from primary angle closure suspect, there are certain variables of the suspect. If the iridocorneal opposition, that's the contact, more than 2 quadrants, it means more than 180 degrees, this indicate that this is a glaucoma suspect. However, if it goes more than 180 degrees, the patient will have acute angle closure glaucoma. And these are the parameters. For the example, the angle opening distance will be less than 250. Here in acute angle closure, it will be less than 200. And in acute angle closure glaucoma, it will be much more less. And you will find peripheral anterior synechia more than 180 degrees. Similarly, the variables for the TISA area, as I said, if it is 0.1, so this is occludable angle. If it is acute angle closure, you will find it less than 0.5 and so on. The difference between a primary angle closure and a primary angle closure glaucoma, that in this variety, this is the acute stage, there will be no optic disc changes or field changes. However, in longer standing cases in which there's peripheral anterior synechia more than 180, the patients will have visual field changes and the optic disc changes. Also, this will affect our management. For example, if you diagnose your patient as a glaucoma suspect, at that time, the just observation, you have to discuss with your patient and show him the OCT picture, and either to choose to do laser peripheral iridotomy, or you can observe your patient. However, in acute angle closure, you have to do laser peripheral iridotomy. And if it is chronic angle, it will be dealt with as open angle glaucoma. You have to manage the patient with laser along with other anti-glaucoma treatment and so on. Another important part of the study of patients with glaucoma disease is the dynamic angle assessment. By dynamic angle assessment is a study the effect of pupil constriction and dilatation, and study the width of the angle and the other the important variables that I have mentioned in response to the dilatation and constriction of the pupil. Also in response to the laser peripheral iridotomy, and you can assist your patient after doing laser peripheral iridotomy whether the angle get improved or not. So the dynamic angle assessment is very important because they found a strong relationship between the laser PI and improvement in the angle parameters. Now, among the another variety of acute angle closure is seen in people with plateau iris configuration. As I explained before, and we have seen in the anatomy of the plateau iris configuration, which is an anatomical problem in the ciliary body and ciliary process, leading to anteriorly positioned ciliary process that is pushing the peripheral iris forward anteriorly so that it will occlude the angle. This is called oppositional angle closure. In acute angle closure, the idiopathic variety is due to pupillary block. However, in plateau iris, it is due to oppositional angle closure. As you can see here, this is the normal anatomy of the iris, and this is the ciliary sulcus and the angle recess here. However, in people with plateau iris, due to abnormality and forward push of the ciliary process of the peripheral part of the iris insertion, so there will be anterior insertion, so this will oppose the angle and close the angle, so that will create angle closure glaucoma. We will not go to the details how we differentiate between plateau iris and acute angle closure glaucoma, as this is beyond the scope of this lecture. However, just I want you to know that one of the big advantage of anterior segment OCT is to determine people with plateau iris, because these people will not benefit from the peripheral iridotomy. They will need more further intervention in the form of peripheral iridoplasty, or sometimes they do surgical iridoplasty. Another variety is in the presence of malignant glaucoma. In malignant glaucoma, there is maldirection of the aqueous, so that it, instead of going from the posterior chamber to the anterior chamber, it will be maldirected and go posteriorly to the vitreous, and this will push the lens iris diaphragm forward and lead to severe closure and shallowing of the angle, and the closure of the angle known as ophthalmia. And OCT plays an important role in the picking up these cases, because sometimes clinically it is very difficult to diagnose. Now, this is a figure shows the plateau iris with what's known as the double hump appearance, that you will find elevation of the iris just beyond the pupil, and at the far periphery of the iris there will be another elevation. This is seen by gonioscopy, and this is the figure of plateau iris, that the iris is flat. However, there is elevation at the insertion of the iris, and this is the angle is occluded, the angle due to opposition of the iris at this area. This is the grades of the angles. This is the place of the iris. So the iris, if it's closed here, it will be causing acute angle closure. This picture shows the malignant glaucoma. You can see this is the shadow of the lens, and nearly iridocorneal contact. The lens is totally touching the cornea, and the iris also totally touching the cornea. This is due to pushing from this area due to maldirection or misdirection of the aqueous. So anterior segment OCT plays important role in differentiation between different types of acute angle closure or acute elevation of the intraocular pressure, either plateau iris or malignant glaucoma, or acute angle closure glaucoma per se. Now we come to the fourth part of this lecture about the application of the anterior segment OCT. We will discuss about its application in corneal disorders, and the most common example is the application in early detection of keratoconus, namely the epithelial mapping and the screening for refractive surgery cases. Now, as you know, keratoconus screening is a big subject that's bothering the doctors for early detection of keratoconus, not only patients with keratoconus, but also for screening for refractive cases, for ectasia screening. And one of the modalities used in the screening and early detection of keratoconus is the use of OCT, high resolution anterior segment OCT for epithelial mapping, as adjuvant to the other modalities available, and not replacement for the tomography, but it is an adjunct to the other available multimodal modalities for assessment of the or early detection of keratoconus. So epithelial mapping is very important part, because as you know that the epithelium is not a passive structure, it is an active remodeling process, and it is smoothening the shape of the cornea so that it will thin over the bulging area and thicken over reduce the thickness of the stroma. So this in patients with normal initial normal tomography or topography, there might be masking for the ectatic signature of this cornea based on this remodeling process. So epithelial mapping useful in unmasking this remodeling effect of the epithelium and hidden keratoconus cases, especially like form thrust keratoconus and subclinical keratoconus. So the typical pattern of the epithelium in the normal cornea is normally it has a homogeneous distribution, normal thickness around between 45 to 55 microns with minimal variations. It is usually homogeneous all over the cornea with mild increase in the thickness in the inferior part as compared to the superior part. This red color is the reverse for the topography colors. The redness indicate that it is thick epithelium as compared to the superior, and this is perhaps due to the mechanical rubbing effect of the eyelid. That's why the superior epithelium is thinner as compared to the inferior epithelium. This is the normal appearance and the normal distribution of the epithelium in the normal cornea. However, in cases of very early keratoconus, the typical donut pattern with the central apical thinning of the corneal epithelium over the apex and surrounded by zone of annular zone of thickening, they named as the donut pattern, is typical for cases of keratoconus. And not only the pattern, we have to look also to the thinnest point of the epithelium. If you find a point in the cornea less than 40 micron, also this is suspicious. Or you find difference between the thinnest point of the epithelium and the thickest epithelium more than 13 micrometer, also this is suspicious. Another example, for example, here this is, you can see that this is the normal cornea. This is normal hypertrophy or thickening of the corneal epithelium inferiorly as compared to the superior. This is the normal pattern. This is the typical donut pattern in keratoconus. Another important thing that I would like to remind you that we should not look to the epithelial maps alone in the assessment of a case of suspected keratoconus or for screening for keratoctasia. We have to combine the three parameters together, that you find out that the area of steepening in the corneal topography in the anterior map or co-localizes also with the posterior elevations, as well as coincides with the thinnest pachymetry in the cornea, and this also coincides with the thinnest epithelial corneal thickness. So you find that the thinnest point in the epithelium coincides with the thinnest point in the cornea, coincides with the steepest point in the cornea anteriorly, and also with the elevation of the posterior surface of the cornea. So all these are additive together, so that increase that this is abnormal cornea, and this will mandate further screening for the biomechanical property of the cornea and so on. So anterior segment OCT plays an important role for ectasia detection and keratoconus screening and unmasking the form thrust keratoconus and subclinical keratoconus. Among the applications of the anterior segment OCT is the use of anterior segment OCT in studying the epithelial pattern or epithelial maps in the ocular surface problems like in dry eye, in epithelial basement membrane dystrophy, in vernal keratoconjunctivitis, and in contact lens warpage. In example for people with a dry eye, most of the studies shows that there will be significant thinning of the corneal epithelium as compared to the normal in people with a dry eye, and this could be due to increased and accelerated death of the corneal epithelium and delay in the turnover and affection of the limbal stem cells. So these people, they will have decrease in the corneal epithelial thickness. Surprisingly, some other studies, they show that the epithelium is more thickened in people with a dry eye, and this is attributed to the continuous rubbing of the eye and itching of the eye. As a result, there will be reactive hypertrophy of the corneal epithelium. And they explain the difference and the variation between these studies, that the anterior segment OCT take in consideration not only the epithelial map, but also it measures the tear film itself. So the measurement reflecting not pure the corneal epithelium, but also the tear film. So this will vary based on the mild or moderate or severe corneal dryness, dryness. So you can see here, for example, this is one case of epithelial mapping for a patient with severe dry eye, and you can see here the thickening of the cornea over this part of the cornea, the central part. So there is, as I said, controversy between doctors and between studies regarding the exact effect of the dryness on the corneal epithelium. Other disease that commonly studied by the use of anterior segment OCT is the epithelial basement membrane dystrophy. And as you know, this is one of the important ocular surface problem that should be picked up, especially before refractive surgery, as these patients will suffer from problems during the surgery if they are missed. This is a picture of the cornea with patient with Meesmann corneal dystrophy or microcystic corneal dystrophy, also known as Cogan's corneal dystrophy. The hallmark feature in the anterior segment OCT is the presence of thickening of the basement membrane. You can see here very thick basement membrane, sometimes duplication of the basement membrane, or even the presence of microcysts, and irregularity due to the surface epithelium irregularity here. And on epithelial mapping, you'll find that there is thickening of the epithelium, especially over the inferior part of the cornea. That's why many studies suggest that we have to use a wide field anterior segment OCT to pick up these cases. Sometimes in the central part you find the cornea is normal, but the changes start in the far periphery. So a wide field will solve this problem. Other diseases that utilizes the anterior segment OCT for evaluation of the epithelial map is the vernal keratoconjunctivitis. And this is due to the variation in the pattern of the corneal epithelium in these people, either with pulpar spring catarrh or with palpebral spring catarrh. They found that there is significant thinning of the epithelium over the superior part. Normally, we have thin epithelium as compared to the inferior epithelium, but this is not more than 5 microns. However, these people, they will have significantly thin cornea, thin epithelium over the superior part as compared to the inferior part, and this is biologically explained by the continuous mechanical rubbing of the lid, which is full of cobblestones. This is the pachymetry map, and this is the epithelial map. Another disease, which is the contact lens warpage. Now, this is another important disease that or problem that we should differentiate between the contact lens warpage and keratoconus. People with the contact lens in keratoconus, usually the remodeling that happens in the corneal epithelium is secondary. The primary disease, that keratoconus, is primarily affecting the stroma, and the stroma thins and bulges forward. The stroma thins and bulges forward, and creating a cone-shaped protrusion. Then the epithelium acts as a smoothing filter that thins over this apex. So this apex, the epithelium will thin over this area. However, in contact lens warpage, due to the mechanical rubbing of the contact lens over the apex of the cornea, so this will induces a reactive hypertrophy of the epithelium over this one due to the mechanical pressure. So the patient will topographically appears as if it is a steepened cornea, but it is not steep. It is due to the hypertrophy of the epithelium. And when you do the epithelial map, you will find the significant hypertrophy of the epithelium here. So the main differentiation between the corneal warpage and keratoconus, the epithelial thickening in corneal warpage syndrome or contact lens warpage, and thinning of the epithelium over the steep cornea in keratoconus. Both of them on the axial map, you might find a steepening of the cornea, but the difference is by the epithelial map, you'll find the difference between the two. Okay, this is another application for the anterior segment OCT based on its high resolution and its quantitative biometric data assessment, is to assess and evaluate the cross-linking cases either before doing the procedure or after the procedure. As you know, we used to say that the safety margin for doing cross-linking to protect the endothelium is a 400 micrometer. You should have a minimum thickness of the cornea of 400 micrometer to do the corneal cross-linking. Nowadays, also for thin corneas, there is special protocols for that, but this is usually applicable for the Dresden protocol. A minimum 400 micrometer is needed, and this is why to protect the endothelium from any damage to the endothelium from the ultraviolet energy. Now, as you can see that in this picture, we have they could reach up to the depth of 304 micrometer, and you should note this. Yes, this is 304. Now, the measurement here should be taken from the stroma. To determine the depth of the demarcation line should be taken from the stroma up to the demarcation line. You shouldn't include the 50 microns of the corneal epithelium, because this is falsely will gives you an impression of deep penetration of the ultraviolet energy. But ideally, the measurement should be taken from the interface from the stroma up to the demarcation line. So this picture shows a very clear demarcation line, suggestive of a successful cross-linking procedure, but this doesn't mean that there is a proportional stability in the biomechanical property of the cornea. This should be very clear. Now, what's the demarcation line? The demarcation line just only represents a transitional zone in the refractive index. The changes in the refractive index believe it to be caused by localized increase in the density of the cross-linked collagen fibers, or there is due to acute healing process or death of the keratocytes. So this is the demarcation line. There is no statistical proportional relationship between the depth of the demarcation line and the degree of biomechanical stability. So this doesn't mean that the deeper the demarcation line, that indicate that you will have more biomechanical stability. There is no statistical studies suggestive of that, but the presence of demarcation line is a good sign suggestive that the cross-linking process successfully has been performed. So this should be very clear. Now I will show another picture. For this patient has thin cornea, and you can see the fibrosis and the inflammation deeper to the endothelium. So this patient sustained damage to the corneal endothelium because of the ultraviolet, and he will have a long-standing corneal haze and edema for a long time, based on the damage happened to the corneal endothelium. So we used to say that the safety margin is 400 micrometer, and this is for the typical classical epithelial of Dresden protocol. Now we come to the fifth section, that is the application of anterior segment OCT in ocular surface pathologies, and also the conscleral pathologies, and also some tumors of the conjunctiva. Now we will speak about the application of the anterior segment in some ocular surface pathologies, like the most famous pterygium and pinguicula. So as you can see in this patient, he has a very small yellowish spot seen by slit lamp. And this is the OCT picture. This is a case of pinguicula. You can see that the epithelium is intact, so this is very important, and this mass is hyporeflective as compared to the epithelium, and there is no any irregularities or any abnormalities apart from this. There is no the epithelium continuous, and there is no sharp demarcation, so this is most likely is going with pinguicula. However, when you look to the for example, this is case of pterygium. This is very clear by slit lamp. You can see the picture by high resolution by the pentacam OCT. Now the first thing that you find, the lesion is confined between the epithelium and the Bowman's membrane. You can see, and this is a huge undulation is seen usually, and this dark colors or hyporeflective areas is due to the vascularity. This is going with pterygium, but the lesion is confined between the epithelium and the Bowman's membrane. This is for pterygium. Now, if we speak about another pathology that can be seen by anterior segment OCT, and actually it's very important to recognize it, is the ocular surface squamous neoplasia. You see this patient has a pathology here in the limbus, as seen by the slit lamp, and one of the main uses of the anterior segment OCT is to find out what could be this pathology. Now, if you can see by OCT, this is the lesion is hyperreflective mass, which is present within the epithelium, and there is abrupt transition. You can see here the epithelium is going straight, then abrupt transition in the epithelium, and a huge thickness. It is said that if the thickness more than 97 micrometer, this is very suggestive of surface squamous neoplasia. And also you notice the shadowing here, underlying shadowing. So this is very suspicious for squamous neoplasia. Now I will show you another pathology. For example, you can see the same pathology. You can differentiate, give a differential diagnosis. This could be a pinguicula, could be a squamous, surface squamous neoplasia or something else. But when they did the OCT, you can see here a hyporeflective mass present underneath the epithelium. There is no abrupt transition. The epithelium is completely intact, as you can see here. And this mass is present subepithelial. And this cyst is the presence of this dark hyporeflective areas of cystis. This is suggestive of nevus. So the one that we have seen is hypo or amelanotic nevus. So this is amelanotic nevus. So you can see now the importance and the significance of the use of the anterior segment OCT in the diagnosis of various ocular surface problems. This slide shows some of the differential points between different ocular surface problem pathologies, namely the nevus and the melanoma and ocular squamous cell neoplasia. First of all, the epithelium. There will be normal epithelium continuity and contour for the nevus, and there will be gradual transition from normal to abnormal epithelium in melanoma. However, in the ocular surface cell neoplasia, you will notice that the pathology is mainly confined to the epithelium. This is the epithelium, and there is an abrupt transition from the normal epithelium to the abnormal epithelium, which is hyperreflective, as you can see here. So it is mainly confined to the epithelium. However, in melanoma, it will be in the epithelium as well as the deeper structure. That's why it causes posterior shadowing because of the increased pigmentations and the presence of intraepithelial cystis present inside the pathology, which shows as a hyperreflective areas here as seen in the anterior segment OCT. So this is the main differential points, and this is very important, especially in the presence of amelanotic nevus, which might be difficult clinically to diagnose because it resembles many other pathologies like Bengicula. The other differential point, which is very important, is the epithelial thickness. If you find the epithelial thickness more than 97 micrometer, this is strongly suggestive of ocular squamous cell neoplasia as compared to other pathologies like benign pterygium or nevus or something else. So this is mandate to do either biopsy or to start the treatment. That's why ocular anterior segment OCT as a non-invasive way of diagnosing these diseases is very important as an optical biopsy. That's why it is named as an optical biopsy. Now we will speak about the application in one of the modern application in infectious and non-infectious keratitis. The other important application for the anterior segment OCT in infectious keratitis, it plays an important role as adjuvant or adjunct modality of imaging to determine the extent of the disease, as well as to monitor the follow-up and response to the treatment. As you know, in most of the places, the diagnosis of infectious keratitis based mainly on the clinical examinations, the history, signs, and symptoms, as well as on bacteriological or laboratory investigation. And in some centers, sometimes the presence of confocal in vitro, in vivo confocal microscopy will be diagnostic. The use of anterior segment OCT, although sometimes there is no diagnostic picture by OCT, but its role plays in determining the extent of the inflammation and the depth of the inflammation and the response to the treatment and so on. So this is very important, especially in cases in which there is polymicrobial keratitis, so that you don't know whether your patient is improving to your treatment or not, because sometimes you have a combination of bacterial and fungal keratitis. So you start antibiotic and you see partial improvement, and then the patient is not improving. So the monitor and the follow-up of the case with the OCT is very important. Now, for example, this is case of viral keratitis or disciform keratitis. There is haziness as seen by the slit lamp here in this part of the cornea, and in the OCT you can see clearly the presence of increase in the corneal thickness due to the edema, and also the presence of hyperreflective spots in the endothelium, suggestive of endotheliitis, which is accompanying the keratitis. Another thing, for example, here in bacterial keratitis, you can see there is a small patch with a positive fluorescein staining here in the cornea, and on OCT picture you can see clearly the lesion, and you can monitor your patient once you start the treatment. And as I said, there is no diagnostic picture seen for each type of infections that is seen by OCT, but it helps you to monitor the case and follow the case. This is another case of bacterial keratitis. As you can see here, there is diffuse haziness in the inferior part of the cornea with ulcerations, and on the OCT clearly you can see the ulceration as seen here in the cornea, and the diffuse haze forming up to the middle part of the stroma and discontinuity of the epithelium. Now, as far as fungal keratitis, you can see this is a white patch here in the paracentral part of the cornea, and in the OCT picture you can see very clearly the feathery appearance of the keratitis and the diffuse haze involving the cornea and the elevation on the surface of the epithelium. This is strongly suggestive of fungal keratitis and the presence of the posterior shadowing, as you can see here. Another case here, for example, diffuse haziness involving most of the part of the cornea and multiple lesions. You can see here there is a lesion here and lesion here. So this patient in OCT shows diffuse thickening and haziness of the cornea with decreased thickness of the cornea, and this is the retrolental or endothelial membrane and characteristic of the exudates that's seen in the anterior chamber. So this is very strongly suggestive of fungal keratitis. So finally, as I said, that there is no diagnostic picture by OCT for each organism, but there is some points in favor of viral or fungal or bacterial, and the most important is the monitor and follow up of your case using the anterior segment OCT. Now we come to the seventh applications or the clinical applications of the anterior segment OCT as an objective assessment tool is its use in refractive surgery and assessing the patient either preoperatively or post-operatively after refractive surgery. Preoperatively, we have to screen the patient whether he's eligible for this type of refractive procedure, whatever as BRK or LASIK or SMILE, based on the corneal thickness, and one of the important determinant is the residual stromal bed. Now, the residual stromal bed is the amount of thickness of the cornea after we subtract the central corneal thickness from the flap thickness and the ablation depth. The ablation depth equal to the amount that we want to correct, how many diopters, multiplied by between 12 to 16 microns. This will provide the amount of ablation depth. So the minimum residual stromal bed that's allowed to perform the refractive procedure is 250 micron. This is for a LASIK procedure. And of course, we have to rule out and exclude any other contraindications apart from the residual stromal bed, like as we have explained before, the presence of form frost keratoconus or any abnormalities in the cornea, like corneal dystrophies or any thin corneas. Any red flags should be detected and excluded, and keep in mind the masking effect of the epithelium, as we said before, that might mask hidden or form of frost keratoconus. So all these preoperative assessments are done as a screening tool for all patients who are willing to do refractive surgery. Of course, this is done on combination or in conjunction with other tools, as the corneal tomography and other procedures to screen for refractive cases. Now, this is an example of a case who underwent LASIK procedure. You can see here that this is the epithelial thickness 54 microns, and this is the flap thickness 125 microns, and the residual stromal bed is 438. So the total thickness of the cornea is around 500. So this is a good case underwent LASIK procedure. So by this way we can precisely determine the eligibility of the patient for refractive surgery. Now, another assessment apart from the LASIK and the flap, we come to the cap that's done during the SMILE procedure. The same thing, we have to assess the patients to determine the thickness, how much amount that we are willing to remove, and the diameter and everything related to the SMILE procedure and find out any red flags for this procedure. And among the assessment also post-operatively, we have to determine the risk of post-operative ectasia after doing the surgery, because even you take your utmost precautions, you don't know, some cases they might be missed, and the patient may be at risk of post-LASIK ectasia. And if we detect them early, so we can manage them very early and avoid significant complications. Now, among the other complications or the post-operative assessment of the patients is if there is any problem. For example, like in this patient has what's known as interface keratitis, or due to accumulation of cleft-like space between the flap and after doing the SMILE. This is after a SMILE, or after the flap procedure, there might be a cleft formation with collection of fluids. So this will make some sort of interstitial keratitis. So we can pick them by the use of anterior segment OCT to detect these cases. Other complications of refractive surgery that can be very clearly followed by or detected by the anterior segment OCT is the epithelial ingrowth, which is defined by that the epithelial will grow and migrate below the flap, in the interface between the flap and the stroma. And this will create a hyperreflective band seen by OCT. This is an epithelial ingrowth. You can see here the white area. And it ranges from mild degree to severe degree, and the management based on the severity. If it is just mild, it might just only observations. If it is significant, you might need to do elevation of the flap and irrigation and washing this bed. This is the appearance in the anterior segment OCT as a hyperreflective band seen in the interface between the flap and the stroma. Another complication is the microundulation that is seen in the Bowman's membrane, as you can see here. This is usually commonly seen following the extensive manipulations in patients who underwent SMILE procedure. So the bed here will be undulated. So initially the patient will suffer from poor contrast and high order aberrations, and he will not be comfortable. But later on it will disappear, or you might need to introduce a spatula and smoothly tamponade this area so that you reduce the irregularity seen here. This is one of the complications of the SMILE procedures. Other procedure that can be seen and followed by the anterior segment OCT is the position and the location of the intracorneal rings, as you can see here, very nicely placed intracorneal rings. The determination of the tissue above the ring and below the ring is very important to determine if there is any risk of complication. You know, when we implant the intercorneal ring, at least 80% of the thickness of the cornea, this should be the place of the tunnel. And if it is below than this, there is the risk of intrusion or inside the anterior chamber. For example, this patient, you can see that the ring here is very nearly to encroach into the anterior chamber, because the residual bed here is small. So this patient at risk of encroaching in the anterior chamber, better to change or remove this intracorneal ring. So all these are the clinical applications of the anterior segment OCT, either preoperatively to detect any risk of ectasia, or postoperatively to determine if there is any complication or follow up your cases. Now we come to the 8th section of this lecture regarding the clinical application of anterior segment OCT in cataract surgery and in IOL implantation, either for cataract or for refractive reasons. You know, now most of the 4th generation IOL optical biometry machines that using the swept source OCT for precise measurement of the axial length of the eye. And this precise measurement is very important, especially in phakic IOL implantations, and also for more detailed information about the biometrics of the eye, like the AC depth and the lens thickness and the effective lens positioning. All these need a precise measurement tools, which is done by objectively done by this swept source OCT, integrated along with the Pentacam, as in the Pentacam AXL, or in IOL Master 700. All these provide precise measurement for the axial length and then very accurate measurement of the power of the lens needed, especially in cases where there is a special scenario like post-refractive cases after LASIK procedures, proper assessment of the total power of the cornea, and proper measurement of the effective lens position. But this doesn't rule out or exclude the role of ultrasound. Sometimes in critical cases like in dense cataract, we still might need to use the ultrasound in cases of dense cataract. But the OCT is very accurate, especially in the pachymetry, corneal thickness, as well as the effective lens positioning and in the lens thickness. Another important applications, as I said, that's its role in determining the vault of the lens and phakic lens implantation. Now, the vault here is very important either in phakic anterior lens implantation or in ICL implantations. I will explain later about the measurement of the vault and how we measure the vault. That's the distance between the lens and the cornea. This is the crystalline lens, and also we measure from the ICL to the lens. So the safety margin or the ideal vault should be between 250 to 750. That is 250 from the lens and 750 microns from the iris. If it is too close than 250, this might lead to anterior subcapsular cataract. And if it is more than 750, this will lead to rubbing with the iris and the lens. This will lead to pigment dispersion. This is for the ICL. Now, for the anterior chamber IOLs, the minimum lens width should be at least 2.5 to 2.8 millimeter is required. Similarly for the ICL. So these measurements are very important and is not done by ultrasound. It is done by swept source OCT. Now, how we measure the vault? Normally, if we want to measure the vault of the lens, we draw a horizontal line between the scleral spur. We determine the scleral spur here and the scleral spur here, and draw a horizontal line. Then we draw another vertical line to the corneal endothelium. The part of the lens above this line is the amount of the lens vault. This is done for the crystalline lens, that's the normal lens, or also we do it for the ICL or phakic lenses. So this is a slide shows the how we measure the vault. This is the ICL. So we have to keep a minimum 250 micron from the lens to avoid cataract formation, and minimum 750 from the iris to avoid pigment dispersion. Now, if you look to this slide, for example, the slide in the right side here, you can see that the lens implanted in the anterior chamber, and it is very, very close to the cornea, nearly reaching to the cornea, and you can see the corneal thickness is very thick because of the corneal edema due to damage to the endothelium. And this is a very high vault. And also you notice that the abnormality of the iris, it might be an plateau iris syndrome, or sometimes this is due to malignant glaucoma in which there is push from the posteriorly to the forward, so that the lens iris diaphragm is pushed forward and the cornea in contact with the endothelium. Now, after solving the problem of this patient by treating him with anti-glaucoma and whatsoever, or in these cases, an urgent reformation of the anterior chamber is needed by injection of viscoelastic material. So this is the normal depth of the lens, and this is the vault of the lens is significantly high from the corneal endothelium. So this is very important measurements and parameters are done by the help of the anterior segment OCT. Now we will shift to another dimension in our discussion about the clinical application of anterior segment OCT to the use of the what's known as functional OCT. By functional OCT, we not only assess the structure and as in standard OCT, but we assess the function of the structure, like the OCT elastography. That's we assess the biomechanical properties and the biological property of the tissue like elasticity and stiffness, as well as we assess the vascular supply of the anterior segment for the iris, as well as for the sclera or the conjunctiva. So this is a paramount shift from the assessment of the anatomy toward the assessment of the mechanical property of the tissue. And the basic principle depends on that we create a shear wave speed map. This is the shear wave speed map. By stimulating the cornea by a micro pulse buff stimulator, we stimulate a very minor mechanical movement of the structure by ultrasound or by air buff, so that this wave will propagate within the tissue based on the resistance they face in the tissue and based on the biological property of this tissue, so that based on a special mechanical or mathematical calculation we can estimate the resistance and the stiffness of that tissue based on determining the speed wave of this the shear wave speed in this structure. So this is the speed wave, the wave speed mapping, as you can see here. And the interesting thing that we can determine the property of each layer of the cornea. So we can determine the stiffness of the epithelium as well as the stiffness of the bomas membrane, stroma, dismus membrane, and endothelium. So this is the speed that we create by between 2 to 4 meter per second. And then we can determine by mathematical calculation this speed is converted into a shear modulus. Now we have spoken before when we spoke in the lecture of the corneal biomechanics about the types of the elastic modulus, that one of them is the shear modulus. So by converting this speed mapped into a shear modulus, we can have an idea about the elastic property of the tissue. So this is a tremendous or paradigm shift from the assessment of the structure toward the assessment of the function. Similarly here, this is the traditional classical OCT that assesses the thickness of the epithelium, stroma, and everything. But now, by this OCT elastography, we convert this into a shear speed map. This map, each color represents the stiffness of each layer, and surprisingly they found that there is a steep gradient of the stiffness from the superficial part of the cornea toward the deep part. So the most superficial part is the more stiff part of the cornea, and the deepest part of the cornea is the least stiff part of the cornea. So there is a steep gradient like this way. So this is very important in studying the function of the biological property of the cornea. As I said, that by this OCT elastography, which shows the different layers of the cornea, but not this time layer by layer as in the structural OCT. It shows them according to the stiffness gradient, and they found that the gradient is much more in the outer part of the cornea. The stiffness is much more in the epithelium and bomas layer, and decrease in the stroma, and minimum is in the dismus membrane and the endothelium. And this is very important because this will create what's known as a biomechanical shield. The outer part is the shield that will resist any outer force from outside, so that the stiffness in this part is very high. And we should keep this in consideration when we are doing LASIK or refractive procedure, or you doing the cross-linking, that the stiffness in the outer 1/3 is much more than the stiffness in the inner 2/3 part of the cornea. This is the shear speed map, as I explained before, and this color represents the gradient of the stiffness from the superficial part to the deep part, and this is the shield of the outermost part of the cornea, which resist the deformation from outside. I should, later I will discuss that there is difference between the OCT elastography and the biomechanical properties measured by the Corvus ST. In the Corvus ST, we measure the deformation. When the cornea is exposed to the air or stimulus, there will be deformation of the cornea like this, and we measure the speed of reformation of the cornea after the deformation. That's the principle of the measuring the corneal biomechanical property by the Corvus ST. However, in the OCT elastography, it is something different, because we measure the speed of propagation of this shear wave inside the tissue, and by mathematical calculation we can estimate the shear modulus and then determine the stiffness of the structure. This is another demonstration for the difference between the Corvus ST and the OCT elastography. That in Corvus, as I said, that we measure the whole deformation that happens to the cornea. So when we estimate the corneal biomechanical property, we speak about the global biomechanical property of the cornea as a whole, but not layer by layer as we see in OCT elastography. So in Corvus ST, it is more precise. It opens the door for another concept, which is the local mapping or local biomechanical properties of the tissue. That's we provide information about each layer unlike in the Corvus ST, which provide a global metric calculation for the global corneal mechanical properties of the cornea as a whole. So this is very important because by this way we can detect the subclinical keratoconus or any keratoctasia suspect much earlier than the one which is picked up by the Corvus ST. So this will have a significant implication and evolution in the keratoconus screening protocol, so that OCT elastography will be very much superior in this regard. This is a diagrammatic representation for the patient. For example, this patient with keratoconus with focal defect. As you know, the etiology of keratoconus, as we said before, that due to a focal defect in the corneal biomechanical activity. So this patient, if measured by Corvus ST, although because of the outer shield, as I said before, the outer part is strong and stiff. So when we measure the stiffness here by Corvus ST, which measures the global corneal biomechanical property of the cornea, it will be normal. However, when you measure the local corneal biomechanical property of the cornea using the OCT elastography, you will find that there is a focal defect in the cornea. So by this way, it will detect abnormalities in the function of the cornea much earlier than the Corvus ST, and it will play an important role in the detection of subclinical keratoconus and keratoconus screening protocols. This is the difference between Corvus ST and the OCT elastography. When we discuss about the evolution of ectasia, we used to say that the biomechanical derangement or abnormalities will precede the structural changes that happens in the cornea. So that when you want to pick up early cases of keratoconus, or if you want to set up a very early keratoconus screening program or ectasia screening program, you should rely on the biomechanical changes much more earlier than the structural changes. Now we add another spectrum or another layer of the early detection, is not that we don't just pick up the global corneal biomechanical property of the cornea by Corvus ST, but also we can detect the very early focal changes in the cornea by the use of OCT elastography. So if we want to draw a scheme for this screening program, we start with local biomechanical properties by the use of OCT elastography. Then we can assess the global corneal biomechanical property by the use of Corneal ST, Corvus ST. Then finally we can find out changes in the topography and tomography of the patients. So this is the sequential step ladder pattern of the assessment of the corneal biomechanical property of the cornea. When we apply this principle and utilize the information we gain from the OCT elastography, we will appreciate the significant difference between the LASIK procedure and the SMILE procedure as far as the corneal biomechanical property. The SMILE is preserving the corneal biomechanical property because I said before that the outer part of the cornea act as a shield that protects the cornea. Most of the stiffness is present in the outer part. And when you do LASIK procedure, so you will cut the collagen fibers in this area, and this area will remain always weak even after you retain the flap. That's why the risk of post-refractive ectasia is much more in LASIK as compared to the SMILE procedure, which is based on removing a bucket of stromal tissue from the inner half of the stroma. So we preserve the outer shield of the cornea. That's why we should take this in consideration in guarded cases or in cases with thin cornea, that SMILE will be preferred than the use of LASIK procedures. Now we will come to the another discussion, which is, or another part of the functional assessment of the cornea, which is the use of the anterior segment OCT angiography in the assessment of the vasculature and the blood supply of the anterior segment. We have spoken before about the OCT angiography for the assessment of the posterior segment, but now we will speak from another aspect, that's for the assessment of the anterior segment, and its helpful way in diagnosis some diseases based on the determination of the transmission of the red blood cells in the anterior segment. Now we will speak about the anterior segment OCT angiography for the anterior segment. One of the most important applications of this technology is in studying the vasculature of the cornea. And as you know, the cornea is avascular structures, and due to any chronic inflammations or any scar in the cornea, there might be new vessels in the cornea. Now, just if we depend only on a pure slit lamp examination, it might be difficult clinically to determine whether these blood vessels are functioning or just ghost blood vessels. Now the decision is different completely. Now if you have a flow inside these blood vessels, this indicate activity. However, if there is no flow and empty blood vessels, this will not indicate activity. So by assessing the vasculature of the cornea, starting from determination if there is flow or not, and also develop certain metrics that, by quantifying the amount of the blood vessels, that is the vessel area density, and the vessel length density, and then we can determine depth stratification. That's which layer of the cornea is involved, superficial, deep, or stromal layer. This is very important in deciding for a patient with penetrating keratoplasty, and there is a new vessels. In these new vessels, if they are deep enough, there is a risk of rejection. However, if it is superficial blood vessels, the risk of rejection is less. So by this way, all this information is gathered by the use of corneal new vessel counting, or by anterior segment OCT angiography. As you can see here, this row will shows the slit lamp appearance of the image, and this is the MFAS block. This is the data in one block, and then this is the quantification of the blood vessels in each part of the eye. And then finally we do what's known as a flow overlay, and see the structure whether there is new vessels or not. For example, this is a corneal opacity. As you can see here, the flow overlay shows redness here, so this indicates that there is flow inside this blood vessels. So this is the blood vessels, but we don't know if there is flow or not, but this overlay, we know that there is a flow inside this blood vessels. Similarly, in this section you can see that it color here, so this indicates flow. This indicates that there is activity in this corneal opacity. This is for penetrating keratoplasty. Also, it is important to determine the depth of the new vessels. As I said, if there is deep blood vessels, this might endanger the cornea for the risk of rejection. Now, the most important obstacle for this technology is the two things. Number one, the dense corneal opacity. Now, if you have dense corneal opacity, this will obstacle the underlying structure for, or it will provide poor penetration for the waves. The other thing, when we study the iris anatomy or the iris vasculature, the presence of pigmentation and heavy pigmentation will be another barrier for the proper visualization of the details of the iris. So we have to keep this in mind. One of the other important applications of the anterior segment OCT is the studying of the different lesions of the iris, as you can see here by the slit lamp, and determine whether they are benign or not benign based on the vasculature. This is an iris of freckles, which is a normal age-related problems can be seen, and this is the MFAS image, and this is the also MFAS image of the blood vessels, and they compare these blood vessels with the normal anatomy. It is normal, so this is most likely this is an iris freckles. However, when you look to the nevus, this is the nevus, this is the corresponding MFAS image. Now you see there is this organization of the internal structure of the blood vessels in this area. This area is corresponding to this shadow. So, and this is the blood vessel. Here there is this organization. So this is indicate that this is a nevus, but it is not highly vascular or abnormal blood vessels that might be suspicious for something else. Now this is a patient with iris cyst. You can see the brown shadow here appearing from the pupil dilated, and this is the MFAS image. This is an iris shadow, and due to this cyst is filled with fluid, so the picture here you see appears as a black. This is called as void. So this indicates there is no any activity, no blood vessels inside. So most likely this is due to a pure iris cyst, and it is filled with fluid. So you can see how the importance of the anterior segment OCT in determining different structures without any incision, non-invasive technique to study the structures, and we can supplement this with another techniques of examination. But this is the advantage that it is non-invasive techniques, especially when there is suspicion of tumors. Now we reach to the final section of this lecture regarding what's the future prospect of this newly emerging technology and other competitors like the sham flow technology or the Pentacam. As you know, that the new trend now and the future prospect of this technology is not that they are one replacing the other. Now, the most gold standard techniques for screening of the cornea and the anterior segment is the anterior segment OCT and the pentacam. And the future prospect is that both of them are complementary to each other. For example, you can see that the resolution of the anterior segment OCT is very high as compared to the pentacam, reaching 5 to 10 microns. However, in the pentacam is around 25 microns. So for a microscopic structure detail of the cornea, the anterior segment OCT has high resolution as compared to the pentacam. However, the pentacam has very good assessment of and robust assessment for the posterior surface of the cornea. So it is superior than the anterior segment OCT for the assessment of the posterior surface of the cornea and to have a global view and shape of the cornea. So both of them are complementary to each other. So the future prospect that both of them are synergistic to each other. When we say synergistic, it means that not 1 plus 1 equal to 2, but 1 plus 1 equal to more than 2, because the additive effect of the combination of these two technologies provide very huge resolution in the form of pentacam OCT, reaching up to 1.9 resolution and more microscopic details of the cornea. So both of them are provide very high microscopic structure of the cornea. Of course, as you know, that both that pentacam is very mandatory for any ectasia screening and keratoconus screening. However, the anterior segment OCT is a must for any refractive screening. And for keratoconus screening, it is needed, especially when there is a red or there is a green flag from the bad display from pentacam. We will shift the patient to the anterior segment OCT to evaluate the epithelium and pick up if there is any element of form thrust keratoconus or subclinical keratoconus. So both of them represent the gold standard for any ectasia screening or keratoconus screening. So before I finish this lecture, the final home message to you that both of them, the pentacam and the OCT, are essential diagnostic tools, and better to use them in synergism to each other to fill the gap that's present in any aspect of one of them. And the anterior segment OCT forms the basis for any quantitative non-invasive assessment of the anterior segment. This is the gold standard for glaucoma assessment, especially the angle. It is much superior than the traditional gonioscopy. Also, it is the gold standard for any epithelial mapping, and this is the new trend nowadays for any ectasia screening. So this is the importance of the anterior segment OCT, and we have seen all the possible clinical application, and still there is a lot of another applications I didn't mention in this lecture, like the application and the use of contact lens clinics, determination the gap or the tear film interface between the contact lens and the eye, also in the use of piggyback contact lenses, and many other applications that I couldn't include them in this lecture so that I don't want the lecture to be very long for you. By this level, we reach to the end of our lecture. I hope that you have benefited from this lecture. Thank you for your patience and your audience. And I hope that I could highlighted some of the spotlights about the importance of anterior segment OCT as emerging imaging technology that's competing with the slit lamp and might replace the slit lamp at one time. So I will announce here for the next session or series of lectures will be about the anterior uveitis. We will provide 4 lectures about the for anterior uveitis postgraduate level. These lectures regarding the fundamentals of uveitis. Then we will speak about infectious anterior uveitis, then non-infectious and systemic anterior uveitis. Then we will provide a case-based discussion and postgraduate level of discussion regarding uveitis. Looking forward to meet you soon in another session. Thank you very much, and I hope that you will be safe and in peace.